Hi, it's Dr. Mann, OBGYN and Lifestyle Medicine. Today was a special day at Maimonides. We had a day-long symposium, Maimonides Health, Maternal and Neonatal Morbidity Reduction Symposium. It's the second annual program. Many speakers about fascinating topics, and I thought I would share some of them with you. Now, this was actually a grant from the New York State Department of Health that paid for the symposium because Maimonides is a regional perinatal center. I know that over the years there's been a lot of controversies about Maimonides, Save Maimonides and all of this, but I have to tell you that the data at Maimonides support good outcomes for mothers and babies, and I continue to maintain that, having experienced it myself as I work at Maimonides Medical Center. I'm not getting paid to advertise for Maimonides. What I want is simply that our women, the women in our community, should think very carefully before they go to deliver at hospitals other than Maimonides Medical Center. So there were a bunch of speakers. It was from 9 a.m. to 5 p.m. with very short breaks. It was very intensive, and I would like to read off some of the speakers to you and what some of their messages were. First of all, the conference or symposium was headed by Dr. Sandra McCalla. She is the Vice Quality for Chair at Maimonides Medical Center, Department of OBGYN. I know her for many years. She is maternal fetal medicine. And the other moderator was Dr. Alec Butada. He's actually the chief of newborn medicine, and he oversees the neonatal ICU. Our chairman, Dr. Chudnoff, gave greetings. And then the organizer of the conference, who is Dr. Natasha Nurse Clark, she's also a nurse, but her last name is Nurse. She is the one who organized the conference. So I'm just going to run through the speakers, and you'll see the sorts of topics that are of interest and are very current. The first speaker was Dr. Yonit Lax. She is the chief of pediatric community health at Maimonides Health, and she oversees something called the Brooklyn Parenting Center, which basically exists to improve neonatal outcomes and pediatric outcomes by providing services to women who might be lacking in different types of support, be it mental issues or emotional issues or social issues or financial issues. And so it's a very important community program. I have to admit, it does not seem to me that the Orthodox Jewish community is taking advantage of the Brooklyn Parenting Center, but I haven't looked into it much. It could be they are taking advantage, but as a rule, I find that sometimes some of these programs that Maimonides will start and promote do not necessarily address the needs of the frum community. This is a topic for another day. The next speaker was Dr. Alicia McKay. She is a urogynecologist. She's a gynecologist that took a fellowship in female urology, and she was describing the Pearl program, which is a program that Maimonides offers for women that might have different musculoskeletal issues or continence issues after childbirth. Continence meaning able to control urination and the bowels as well. So this program is actually functioning already, and it's going to be expanding. So she was describing some of the services that were offered. Now, the next topic was actually fascinating. Dr. Gupta, who is a neonatologist, she is a specialist in ICU, newborn ICU, NICU as we say. She is very involved in the so-called Vermont-Oxford data to implement change. What does that mean? There is an organization up in Vermont that collects data internationally on various neonatal ICUs that participate. And so using this data collection, they can determine quality measures and compare themselves to other institutions. And so Maimonides actually is doing really well in most of the categories, even superior to other neonatal ICUs around the world. One of the topics that she discussed was keeping the baby warm, a severely low birth weight infant. It seems that the outcome is much better when the baby is warmed, and so they have instituted protocols in labor and delivery. Many of these very low birth weight babies are born by cesarean. All of the very low birth weight babies are born in the operating room. They're not born in a birthing room. It's a cold environment. And so right away, they slip the baby into this cute little silver sleeping bag right up to its neck. And so this measure and some others have resulted in much better outcomes. She actually went through a lot of different outcomes, and they were able to see that retinopathy of prematurity was something that they need to keep working on. So they are actively doing research and looking at different interventions to improve in that area. But in all the other areas, they are doing really a superior job. That was a fascinating talk. Then we had a number of women talking about nursing, breastfeeding, which our community takes for granted, but it's not taken for granted in other communities. I think our community is stellar in terms of nursing newborns. We've seen our mothers do it, our grandmothers do it, our sisters do it. A lot of the other communities do not see their family members doing it. And so for them, it's a bit of a pioneering type of activity to initiate a nursing lifestyle. A lot of women don't have the same type of support as we do in the frum community for nursing. And so this was the Perinatal Nursing Inpatient Breastfeeding Project by Dolly Allen. And I must admit that they really stepped it up in the postpartum unit. They really are encouraging it. I have found, even in the clinic where I sometimes work, the residents are trained that they have to offer breast pumps to women while they're still pregnant and provide them with breast pumps. You would have never seen that in previous years. This is really a very strong, it's actually practically a campaign, and it's long overdue. So that was a very interesting talk. The next talk was actually Dr. Soll, S-O-L-L, from that Vermont program, and he spoke about avoiding neurologic or brain injury in very low birth weight babies, preterm babies. He spoke about the stuff that we kind of already know, which is giving steroids strategically and giving magnesium sulfate for neuroprotection. So these are interventions that Maimonides is already doing. He also explored some other interventions which are not so much in use anymore, like surfactant, which is a kind of soapy substance that is put into the baby's lungs to help the oxygen pass through into the lungs. But with the use of steroids and the magnesium, and also what they call CPAP, which is the little prongs in the nose of the baby, all of this is kind of taking the place of that surfactant. And the other drug he mentioned was indomethacin, but these were tried and sort of fell by the wayside because no real benefit was seen. So that was also a very interesting talk. It was a very, very busy morning. We barely got a minute to breathe. Okay, now the next talk was by one of our own, Dr. Thomasina Ellison. She is an African American, or she might say Black highly, highly experienced OBGYN doctor. And the name of her talk was VBAC Risk Calculator, Eliminating Race in Clinical Algorithms. Now, that sounds very complicated, but what does it mean? It means like this. If a woman has had a cesarean and she wants to have a trial of labor, the American College of OBGYN, which is our academic organization, which I have a lot of, let's say, skepticism towards, and this is definitely one of the areas where I'm very skeptical. In fact, I happen to have a slide about this very subject. What is a VBAC calculator? What they do is everything has to be measured in medicine. You can't just go according to your gut. So when you measure everything, you have to have cutoff values, et cetera, et cetera. So they have this thing called a VBAC calculator where they calculate what is a woman's chance of having a successful vaginal birth after a cesarean, right? Now, I think kind of it's absurd because until the woman is in labor, you really have no idea if she's going to succeed and have her baby after a cesarean. And therefore, I think that this whole thing is a big waste of time. But I will say one thing, that one of the important measures in this calculation is the BMI, or the body mass index, or what it means is if you're fat, they're calculating that your chances of having a successful vaginal birth after cesarean are very low. So I always show this slide in terms of lifestyle medicine because I say to women, look, they're writing you off. You want to have a trial of labor after cesarean, they're writing you off. I know that also myself. When I counsel a woman for a VBAC, I'm like, as soon as you have a positive pregnancy test, you come in, I'm going to give you a big lecture on how to make yourself into an athlete so you can have a successful VBAC. So what was Dr. Ellison's point? New York, I should say the United States of America compared to other countries, with this silly, ridiculous VBAC calculator is even more ridiculous because it has race in there. And so if you're Black or Hispanic, you lose points because the data show that Black and Hispanic women have lower rates of successful VBACs. Now, this is just another, like, more fuel for her fire about the social determinants of care and institutional racism, meaning we have negative attitudes towards Blacks and Hispanics, and so therefore we're much less likely to give them a successful trial of labor. It doesn't really interest me because I treat all women the same. However, we know that Black women in general are more obese coming into labor and delivery, so that already reduces their chance of success. And because they tend to eat a lot more ultra-processed food because of all the different reasons that we're not getting into now, they tend to be less healthy. So they're more obese, they're less healthy, and maybe their placentas don't function as well, and all different types of reasons that would lead to a lower success rate in VBACs. So my take on this whole discussion that Dr. Ellison had was, she was looking at it from a perspective of race. I was looking at it from a perspective of give a woman a fair chance. Throw out the VBAC calculator. In fact, Maimonides, they ran a small survey asking how many doctors regularly used a VBAC calculator, and it was about 1% of all. I'm talking about not just doctors, midwives, PAs, all, any provider is completely uninterested in a VBAC calculator. And this just goes to show you how detached the American College of OBGYN is compared to its constituency of physicians and other providers. They have people, they're paying people who knows how much money to come up with clinically irrelevant guidelines. There are other clinically irrelevant guidelines, especially how many hours in the second stage and all these other things, which I've spoken about elsewhere. But this was very awesome. And although my reason for thinking that it was an awesome talk was different than Dr. Ellison's, I went up to her after the talk and I congratulated her. And I also plan on sending her an email to show her that within the perspective and using the lens of lifestyle medicine, we also have a lot to learn from this VBAC calculator. The next speaker was a so-called keynote speaker. The keynote speaker means it's the most famous speaker, and this is like the biggest talk. So the keynote speaker was James V. McDonald, MD, MPH. Also, he has a Master of Public Health. He's the Commissioner of Health for the New York State Department of Health. And that is a very big job. He's responsible for billions of dollars, literally billions, the distribution of billions of dollars for healthcare. And he spoke about many, many different things. And really, he's very forward-thinking. He's very, very instrumental, for example, in instituting the doula program. And he also was responsible for making sure that doulas get adequate compensation, which is very important because doulas need to stay up at night and they need to be compensated for what they do. He also, for example, was very pro having more dental programs around. And we know in our community there is less, or let's say suboptimal availability of dental care. It's a big deal. And he said to the audience, why am I in front of a bunch of OBGYNs and neonatologists talking about dental care? And he said, well, if you can eat a healthy diet, you need teeth. You need good teeth to work, to chew the food. So he was funny, but he was definitely on the mark. He was asked a question which was very interesting, which was, how does he get the legislature to move? How does he get legislature to step up to the plate to get these healthy programs going? And he answered, I try not to go to the legislature. I try to go directly to the insurance companies. Because if I could convince them that an intervention is going to affect and improve their bottom line by preventing chronic illness, I could get the insurance company on board and I can bypass the legislature. And I thought that that was very wise and very profound. Okay, so then we had a lunch break where everyone went up to the 5th floor to the boardroom. And they had kosher food on one side and non-kosher food on the other side. But I had to make a lot of phone calls and I couldn't get up there. Not that I would necessarily eat what was there, but maybe there was something there. So on one end of the room was Orchidea, which is like a very fancy Brooklyn restaurant of dairy kosher food. And on the other end was mamish non-kosher food. And of course, everyone had helped themselves to everything. And I could just imagine going back and forth and everybody putting their spoons in everything. So I didn't eat any of that food. But that was fine because I had my oatmeal from the cafeteria that I never got to eat because I was so busy that morning. So that was a very nice lunch. And they also had poster presentations. And they really are focusing on women's health. So you got to eat, and then you could like tour around and look at the different poster presentations. So that was that, and then we had a whole run of some more speakers. At 1 o'clock we had Marilyn Cassia, MD. She is the medical director in the Division of Family Health at the New York State Department of Health. And she was speaking about the New York State Birth Equity Improvement Project, meaning we know that there is a great disparity, and really sometimes it gets to be heartbreaking because all women are our patients. It's not that I only have one ethnic category of patients. When we see women coming in, Black and Hispanic women especially, and they're unwell and they're having adverse outcomes, it is really heartbreaking because so much of this can be prevented and changed. So she was speaking about different programs that they're trying to implement to raise up health literacy access and different types of lifestyle interventions, which I'm very interested in, to try to improve the outcomes for these women. So that was an interesting talk. The next one was even more fascinating, although actually I've heard this sort of stuff before. The speaker was Adrienne Combs. She's got a whole bunch of degrees, and she belongs to Northwell Health. So Northwell came from North Shore. They bought up Staten Island Hospital. They have over 30,000 births annually, and because they're a very, very good business model, they're able to really attack this unnecessarily high, dangerous cesarean rate. And she spoke about how she was attracted to Northwell because she saw the opportunity to amass very valuable data and really make an impact on the cesarean rate. So she spoke about the so-called NTSV. I've spoken about it before on a different video. What is NTSV? That is a kind of a catch-all phrase, which means nullip, term, singleton, vertex. That means a woman coming into the hospital, it's her first baby, the head's down, she's full term, and what was the last one? And it's one baby. Nullip, first baby, T, term, S, singleton, V, vertex, head down. So this is like your average low-risk patient walking into the hospital. What is the risk for cesarean? And this is why a lot of women are choosing home birth or birthing center births, because it's absurdly, almost criminally high. We're talking 30% or more in many, many hospital settings. In 1985 to 89, when I was doing my residency, the overall cesarean rate was 6%. So there's something terribly, fundamentally, pathologically wrong about how obstetrics is being practiced in this day and age. So the job of this woman is to collect data and try to figure out how to lower the cesarean rate, okay? So a lot of it is exposure, meaning just when physicians know what their rate is, they might get so embarrassed that they might try a little harder to get their patient delivered vaginally. This is, to me, a very sickening idea, because you would think, ideally, why would somebody just casually do a cesarean and then, to try to save themselves, stop doing a cesarean? Really, cesareans can be life-saving, and I'll diverge for a moment to tell you about a life-saving cesarean that I performed yesterday. But in general, these unnecessary cesareans are, I call them crimes against women, because a woman should not have her uterus cut open for the wrong reason, only for the right reasons. So what they did in this program is their goal was to reduce the cesarean section rate by 5%. And anyone who got it down by 5%, no matter where they started from, they got a congratulations and a certificate and an award and everything else. And I think it's a travesty. I'm sorry. Open your eyes. Open your eyes. That's your goal, 5%? Well, it just shows how really terrible OBGYN is right now. I'm sorry to say it. It's true. That's all. Everyone loved the talk. I also like the talk because it shows at least something is being done, and they really were able to reduce their cesarean rate. But it's so profoundly whacked that it's like a drop in the bucket. Okay, for those women who are saved from an unnecessary cesarean, that's great for them, but there are so many more who are still having unnecessary cesareans. One interesting thing about her talk was that more and more women are having cesarean on demand, up to 12% of women giving birth in some of these hospitals. And now that's also a sign of a completely misguided population. And this is part of the problem with social media, where women go on and they think they're educating themselves, but they might be educated, but they're not informed. And I actually spoke to a family about this the other day. You can be educated, but you could be not informed. And there's a very, very big difference, because you could learn facts about something, but you're not in the know. And that's why Orthodox Jewish people have these so-called askanim, or these advocates, because they tend to be more in the know. Really, the truth is they're not professionals. They're not totally in the know. But because they have a relationship with experts, they're able to seek out expert opinion in a very expedited way and guide people to do the right thing. And a lot of the other people in our community, I should say in the community of Brooklyn, New York, and maybe all over, since they don't have these advocates, they could try to educate themselves, but they're not informed, and then they start to ask for an elective cesarean. So I think that's kind of a sad situation, and it's only gonna have a ripple effect down the road when they have all sorts of complications due to the fact that they have a scar on their uterus and subsequent pregnancies. I'm going to get into that in a little while. So that was a very fascinating talk. Now, the next speaker, her name was Mahima Gulati, and she's actually a lifestyle medicine expert, and I was given the honor of introducing her because I am also board certified in lifestyle medicine, as she is. She is an endocrinologist, and she's an internist, and she's running a lifestyle medicine program up in Connecticut. Now, she's originally from India. She's a very bright individual, and she's really lovely. She's friendly and modest, and we really hit it off. I was very honored to introduce her. She was one of the authors of reversing diabetes, type 2 diabetes, using diet. This document came out of the American College of Lifestyle Medicine. So there's a lot going on in the ACLM. But when I got up to introduce her, the first thing I said was, wouldn't it be nice if all our patients could walk through the door of the hospital completely optimized for physiologic birth? What does that mean? It means if all women, when they were pregnant or even before they were pregnant, would take such good care of themselves that when they walk through the door, oh, there we go again, it's midnight, lights off. When they would go through the door, they're in perfect condition for a vaginal birth. That would also make a tremendous dent in the cesarean rate. A lot of women are walking in, even from the Orthodox Jewish population, they gain too much weight, they're eating the wrong food, they're stressed out, they don't sleep, and they're working very hard, and they're just being pulled from every side. And that is something that is going to impact on their labor and delivery and their chances of having a successful birth. So how did my reputation come along? It came along because I would take all these women and I would save them from themselves. What does it mean that I would save them from themselves? Meaning they would come in and they're not optimized for birth, and then we would get a vaginal birth out of it anyway, due to all these heroic things that we would have to do to get them to deliver vaginally. And so that's how we kind of got our reputation. My group was that we had the patience to wait out all these dysfunctional labors and all these babies that were a pound bigger than they should have been, and all these prolonged second stage of labors and pushing and laboring down and all of this business. We just had to wait all of this stuff out, and that's why we had a low cesarean rate and the reputation that we had, that we permitted women to deliver vaginally. But the truth of the matter is, a lot of these women had very dysfunctional labors that needed to be fixed. So getting back to my introduction to Dr. Gulati, I said, wouldn't it be great if everyone would walk through the door really like this is some athletic event here, having a baby? But unfortunately, it's not like that. And then I went on to describe how I got into lifestyle medicine and about Dr. Gulati's interests, which include polycystic ovary syndrome, which is lack of ovulation. And she's also interested, obviously, in lifestyle medicine, culinary medicine, which means using food as medicine. She was interested in employee wellness programs, which is very important. and graduate medical education. We have to teach the residents what to do. And her other area of interest is in lifestyle medicine reimbursements, meaning it's very hard for a lifestyle medicine doctor to make a living. So what do? We want to practice lifestyle medicine. We want to give patients the time that they deserve. So she's working on that. And as well, we have this model called shared medical appointments, which actually works very well in lifestyle medicine because a lot of this information can be given over in a group setting. And I'm actually working on bringing lifestyle medicine into my own practice now, and things are really moving forward. I'm happy to announce when it does get rolled out. You're going to hear about it. And then she's also authored several chapters and all kinds of things. Okay, so she got up and spoke about a case study that she had as an endocrinologist and practicing lifestyle medicine of a woman who was not ovulating. She was very overweight, and she gave her very simple, very, very simple instructions, which was don't eat ultra-processed food. Eat real food. Don't buy food that came out of a factory. Buy your own fresh food and cook it. She didn't give her specific instructions about that, except to avoid ultra-processed food and try to exercise 30 minutes a day. So it took her a while, and she ovulated and she became pregnant. When she was unwell with her PCOS, she actually had to go through in vitro to have a child. But this time, on her own, she also took metformin because she had some insulin resistance, which is ubiquitous now. I still make the joke of, if we were still using paper prescription pads, I would need 4 separate pads, one for Synthroid for thyroid disease, one for metformin for insulin resistance, one for Klonopin for anxiety, and one for Zola for depression. It's like water, we give it out. So getting back to Dr. Gulati's talk, she also mentioned a very famous researcher. It's a very well-known study by a Dr. Ken Hall at the National Institute of Health. I don't think I've ever really discussed it because there's so many other things to discuss, but basically he has a metabolic lab in the National Institute of Health, and what he can do is literally lock up people in these little living areas, and they measure all sorts of different kind of measurements related to metabolic health. So his famous experiment was that he had a group of people and he divided the group in half. One group was given ultra-processed food and the other group was given food, real food. So the participants were told there's no caloric restriction, eat whatever you want as much as you want. So I think you already know what happened. The people in the ultra-processed group ate at least 500 calories more per day compared to the people eating the real food, and they actually gained 2 pounds in 2 weeks. The people eating the real food, they ate as much as they wanted to, and they ate 500 calories less than the ultra-processed group, and they actually lost a couple of pounds at the end of 2 weeks. Then they did the crossover. So the crossover is they switched, and the ultra-processed went to the real food, and the real food went to the ultra-processed, and you already know what happened. That group also started eating more, and they gained back the weight, and those that went to the real food, they lost the weight that they had gained, and Shalom Aleichem. Right. Everybody understands that how this experiment worked. But the thing is that what he was able to show is a cause and effect. Until this landmark study, it was more of an association. Oh yeah, you eat ultra-processed food and you gain weight. Says who? So by this experiment where he controlled everything, he also did what's called DEXA scans, where he was able to see the percentage of body fat that meaning the weight that they gained was fat. It wasn't muscle, it wasn't anything else. So he was able to prove that ultra-processed food causes weight gain, and it also drives overeating. And those are very, very interesting conclusions. Now, in terms of likability of the diet, it turns out that when they were given the surveys afterwards to rank the diet in terms of how did it taste, was it appealing, did you enjoy eating it, they were equivalent. There was no specific predilection to the ultra-processed food. They found whole food to be as satisfying and tasty. So this was a study that Dr. Gulati presented, and people, their jaw kind of drops and like, oh yeah, the light bulb's going on, etc. And I happen to know the study because I'm in lifestyle medicine, but it is a real eye-opener for us. And by the way, today, well, now it's already tomorrow, there was a postscript to an article about one young woman's experience with Ozempic that was published in Bina magazine that I wrote. And in there, I speak about the dangers of ultra-processed foods. So again, I don't get paid by Bina to promote their magazine, but they were gracious and gave me plenty of space to discuss all the relevant points of how we approach food and the role of Ozempic in society at the present time. So that was Dr. Gulati. She also spoke about sleep, and sleep is really number one. Sleep affects our microbiome, the gut bacteria that we have. We really need to focus on sleep. And as I learned very early on in lifestyle medicine, if someone will say to me, I can't exercise, I say to them, well, I learned early on that if you don't sleep, you're not going to exercise because you're not going to have the energy. So this is a lesson for all of us, even though it's already past midnight. But tomorrow I don't have to wake up till 7:30 in the morning. That sleep comes before exercise. And really, in the beginning, if someone is grossly overweight, just carrying around those extra pounds is a form of exercise. So really, the exercise needs to kick in when the weight is being lost, and as you're plateauing and getting down to your final goal weight, that's when exercise in earnest becomes much more important. But if you are insulin resistant, then you have to do the exercise right away, because that is really going to help with improving your blood sugars, etc. So that was the lifestyle medicine. Oh, we still have so many more speakers. Okay, there was from Wyckoff Hospital, there were two speakers there, Daisy Crawford and Amelia Blissett. They spoke about family-centered cesarean birth. What does it mean? It means that we're trying so hard for women to bond with their baby and initiate nursing early, because the earlier you initiate nursing, the better outcomes. This has been proven across the board. Actually, there are a lot of Orthodox Jewish women that they want to sleep when they have their baby. They need to sleep, and so they tend to give in the baby at night, give a bottle, I need my sleep, etc. Really, the data don't totally support that, but the truth of the matter is that that does tend to work for Orthodox Jewish women who have already large families and they know already how to nurse. But when you're talking about someone who had their first baby and we don't know if they're going to be a good nurser or if they're going to have challenges in nursing, I tend to discourage the idea of giving a baby a bottle at night. Now, excuse me, one thing you have to realize is that if a woman would have her baby in the hospital and then once she's stable, send her home already. Why? Because the amount of support she's going to get in the house in terms of her nursing is much better. For example, I know when my daughters have babies, what do? I say to them, go take a nap. I'll watch the baby. I'll listen to all the noises. I'll change the baby. I'll rock the baby. I'll pace with the baby. And then when I realize the baby's hungry, I will bring the baby to you, and you will nurse the baby. You'll wake up, nurse the baby, and then roll over and go back to sleep. And I'll take the baby back again and do all the things over and over. And then in that way, the new mother having the first baby can establish her nursing and still get some quality rest. But that cannot be done in a hospital setting. So although the nursing community, the breastfeeding community, is pushing so hard that mothers in the hospital, new mothers should exclusively breastfeed, it's really not set up for that. It's set up to put the baby in the nursery and sleep at night because there's nobody there to help you anyway, really, right? So what are they coming up with? They're coming up with donor milk, meaning if there's really a need for the mother to rest at night, which obviously there is, and not only at night, around the clock as well. Because what happens when a kimpator or a new birth mother comes home? She has to go lay down. She has to sleep. And everyone understands that. But in the daytime in the hospital, people coming in, waking you up, taking vital signs, education, all kinds of interruptions. It is so not conducive to establishing nursing. And I believe also with the sleep deprivation, it's also, unfortunately, probably a risk factor for postpartum mood issues, which are very common to begin with. So the setup is off. Really, ideally, someone should come in, have a baby, be stable, and go home for first-time mothers. That's my opinion. So this family-centered cesarean birth, what they tried to do, and really there is some wisdom in that. The drape on the mother is a clear drape. The mother can watch her baby being born. And there is one nurse specifically assigned for promoting and fostering the bonding between the newborn and the mother in this setting of a cesarean section. Because think of it, if your C-section rate is 30%, and 1 in 3 women are having a cesarean, you're putting almost more than 30% of women at a disadvantage in terms of initiating breastfeeding. So really what they need to do is reduce the incidence of cesareans, because women who deliver vaginally have a much easier time initiating nursing. But okay, here I am on my soapbox. So what they do in Wycliffe Hospital is they have the clear drape so the woman could see her baby being born. Then the one who is fostering this bonding, they dry the baby, they put the baby on the mother, on her chest, on the other side of the drape. And the baby can lay there, and some babies are very smart. This is the what they do. They sort of crawl towards the mother, towards their milk source after a while when they kind of realize where they are and who their mommy is, and it's like a miraculous thing. So then the baby could stay on her mother for the rest of the surgery. And what happens is that nurse stays with the baby and the mother and goes to the PACU, post-anesthesia care unit, what we used to call a recovery room. And so the mother is with the baby the entire time. Now, that uses up resources. That means they have to dedicate another nurse to stay there and make sure that this bonding and early initiation of breastfeeding occurs. But really, it's worth it because the benefits of nursing are so cosmic that they realize that it's the best thing to do. And they actually got awards for this program, and they've presented it in different places. So this is a very successful program. Now, the next lecture was given by Dr. Kavitha Ram. She is the Associate Chair of Obstetrics at Maimonides. She came from Jamaica Hospital, and she is very pro-physiologic birth. So the name of her talk is Organic Birth, Natural Principles to Reduce Maternal Morbidity. What does it mean? What can we do to lower the C-section rate? What can we do to lower our hemorrhage rates? What can we do? So she was talking about all the things that I talk about. Stay out of bed, don't get strapped into bed, get a doula, use a peanut ball. I don't know if you know what a peanut is. A peanut is kind of, it's a large balloon, firm balloon, like a ball. And it's got two pieces, like parts to it like this, and the middle part is smaller. So she actually taught me something that I was unaware of, and I plan on discussing this with the midwives. This peanut ball is supposed to be used in different ways according to the station of the baby's head. Now, the inlet of the pelvis is where the baby has to enter the pelvis. So we have the inlet, the mid-pelvis, and the outlet. And so the peanut ball is used differently. So the way that she explained it was, in order to encourage the baby's descent into the inlet, and most babies are already in the inlet at the start of labor. They're somewhere in the mid-pelvis at the start of labor, but to encourage that, you use the peanut ball in a sort of symmetric way. And then in the mid-pelvis, you use it in an asymmetric way, meaning that one leg is bent and one leg is straight. And this helps the bones orient in a certain way to encourage the head to negotiate through the mid-pelvis. And then actually she described that we use the peanut in the outlet part of labor. We put it between the ankles in order to orient the leg bones in a certain way to open up the outlet of the pelvis. I thought that was very interesting. And I have seen certain doulas instruct women to actually put their knees together when they're pushing. In real life, I don't know if I see that it makes that much of a difference, but at least conceptually, it's very interesting. So I plan to look into that more. I do extensively use a peanut in women who are on epidural. They're laying there and they're just not doing anything. So we do use the peanut, and I like to rotate women every 20 to 30 minutes to the left, to the right, and hopefully the baby will negotiate the birth canal while the woman's laying there doing absolutely nothing. I don't blame them. I myself had 7 out of 8 epidurals. One I had general anesthesia for because I was hemorrhaging with placenta previa. And thank God my baby is 22 and a half years old and doing quite well for himself. He's in yeshiva in Israel. But you grow up in a culture where epidural is the way to go. And so we have to fight back on these epidurals because we don't want women to have unnecessary cesareans. So that was a very enlightening talk. She also spoke about something that I know about forever, which is hydration, meaning especially if someone is being induced or they're on epidural, the urine has to be clear. Concentrated urine is bad. It leads to dehydration. It's a sign of dehydration, and especially at the level of the uterus and the blood flow into the uterus, it will affect the baby's heart rate. I recently had, a couple of weeks ago, a patient, a black woman with a BMI of 45. I don't even know what her actual weight was. She was morbidly obese. She was being induced for a growth-restricted baby, and I came in and I saw that the nurse had her IV on the pump, 125 cc's an hour, which is a drop in the bucket for this large woman. And I made them give wide open, a couple of liters of fluid, some sugar in there as well, what they call dextrose, and everything perked up. And thankfully she delivered vaginally, and they were so grateful. They sent me a bouquet of flowers. I wasn't in the hospital when it came. So really, we can make an impact with these careful, or let's say simple yet careful approaches to promote what Dr. Ram calls organic birth. Okay, then we had a break, and we still have more lectures. Can you imagine what they packed into one day? Okay, the next talk was Dr. Melissa Walsh, and she spoke about telehealth. I don't really like telehealth. I know when COVID came out, we were doing all this telehealth. I was just sitting in my chair talking to people and getting frustrated, and my legs were getting swollen, like as if I was in an airplane, like flying to Israel for a 12-hour airplane ride. And I said, I just can't do this. And half the people anyway, I wound up sending them to the office because I couldn't help them. OBGYN is a very hands-on type of a thing. But she was talking about using telehealth strategically, meaning there are a lot of counties in the United States, and she showed a map where women really don't have access to care. They have to drive many, many miles to obtain their care. And furthermore, a lot of women leave the doctor's office and they forgot to ask questions, and then when they try to call back, they can't get through, and not all their questions are answered satisfactorily. So they have started this telemedicine. It's very successful, and they were able to show that they were able to screen women for serious diseases just by doing telemedicine and avoid a lot of morbidity. So they were able to demonstrate cost savings through this program, and so the program is funded, and they're continuing to do this. For example, they'll call up, or a woman will call and say, I have a headache. You know, in the old days, you could get through to your doctor, right? So now you can't. So you schedule a telemedicine, you can request one, and someone will call back, and they'll have a video call. And so these kinds of important things like headaches or dizziness or bleeding or any other kind of complaint, fever, difficulty urinating, all these kind of complaints can be handled through a telemedicine visit. So that was a slightly bland presentation, but it's a very, very successful practice. It's called Pomelo. Next, intraoperative cell salvage by Dr. Janet Stein. She's one of ours at Maimonides. She's actually the director of obstetrics. She spoke about women who are hemorrhaging, which unfortunately is a reality. No matter how you try, and I will get to that life-saving cesarean at the end of my talk, because this was one of those types of cases. Hemorrhage is known from the beginning. Rachel Imenu died in childbirth. Our mother Rachel died in childbirth. She had triplets, and I can only imagine that she must have had a failure to contract her uterus after she gave birth. That's my medical opinion. I've spoken about it on previous videos also, but we don't know. We don't know. I wasn't there. I wasn't her midwife. So there are times when women hemorrhage in childbirth, and so we have something called a cell saver, which is that we can collect this blood when there's rapid, brisk bleeding. We can collect the blood, purify it, and actually give the woman back her red blood cells. The studies do demonstrate safety. There are theoretical concerns that some amniotic fluid can be given back to the woman, and that could be dangerous because amniotic fluid can go into the lungs and cause all sorts of catastrophes. That's called amniotic fluid embolism. Actually, it has not been borne out in the studies, and this cell saver method of collecting the red blood cells and giving it back has been found to be safe and cost effective, and that's what Dr. Stein spoke about. So that was a nice short presentation. It wasn't really something new, but rather an approach to make it more mainstream, that people should keep it in mind. The cell saver machine is slightly complicated to use, and doctors don't know how to use it. There are specialists who know how to use it, and the nurses in labor and delivery, a lot of them decided that they were going to get training in it. So it's really the nurses that deserve recognition for operating the cell saver. Next, okay, now we're getting to the wrap-ups. Yes. Okay, so the next doctor to speak was Dr. Per Dar, first trimester screening for placenta accreta spectrum. What does that mean? Dr. Dar works up at Montefiore. I happen to know that a lot of the Rabbanim in my community hold by him in terms of giving his opinion. He's an excellent sonographer, does a lot of research, and one of the important uses of sonograms in this day and age, and because there's so many cesareans and so many scars on the uterus, is what is doing with the placenta. Where is it located? Is it in the scar? Could it be stuck to the scar? And if it is stuck to the scar, it is not easily separated. After the baby is born, the placenta is supposed to separate. And there's actually a cleavage plane, microscopically we call it Nitterbuck's layer, and that's why the placenta is able to separate. But when there's a scar in the uterus, the Nitterbuck's layer is lost in that area, and so if the placenta implants in the region of the scar, that puts the woman at risk for an adherent placenta. So they call it a morbidly adherent placenta. And that sounds scary, so they decided they don't want that term anymore. They're calling it placenta accreta spectrum. It's all kinds of different names. It all means the same thing. What it means is the placenta is stuck and it cannot be separated. And that means that if you don't do something, the woman, God forbid, is going to hemorrhage to death. So the point of Dr. Dar's talk is to use very sophisticated sonography to try to identify women who may have an abnormally adherent placenta. And that's, of course, very interesting. If you can identify it early, you can start to plan. Women can make decisions about what they want to do theoretically with their pregnancy. Do they want to go through with the pregnancy? And what his point was is that some of the imaging that we do later in pregnancy to try to identify these abnormally adherent placentas are not very helpful. So he is doing research to try to identify it as early as possible, when it might even be easier to identify. The other thing that he was talking about was prenatal care altogether. What is the basis for our visit system? Once a month, and then in the 9th month once a week. And he was telling the audience that really that was based on a British system from 100 years ago, when we did not have a lot of technology. And so women had to come very frequently to the doctor, because the doctor basically had his hands to assess what was going on with the mother. And that's how OB was practiced in those days. And he said that we just never got rid of that. And now that we have technology, we don't have to have so many prenatal visits, and women are busy and they're stressed out and they're overextended, and who wants to keep coming to the doctor? I actually myself have instituted that somewhat in women that, not the first baby you have to keep on top of people, but women who are low risk and it's not their first baby and they're under the age of 40, by the way. I see them for a dating sonogram, then we could skip to a 12-week sonogram, and sometimes I just skip to the 20-week sonogram, and then they come for their glucose test at 26 weeks. Then we could skip again to 32 weeks for a growth on the baby. In the 9th month, I'm a little more careful. I do kind of growth in position in the 9th month, and then I start seeing them every 1 to 2 weeks. So I try to eliminate the non-essential visits. He, of course, I believe he's Israeli. Israelis tend to go to maximum lengths when they want to be, let's say, describing some new way of doing something. So he was talking about having the first visit at 12 weeks. I don't agree with that. I like to see women as soon as they have a positive pregnancy test. I really need to know what's going on with them from the very beginning. So those were the two topics of Dr. Dar's talk, and they were very nice. It was a very nice talk. Okay, next we have, here we go. And Dr. Futterman, Itamar Futterman, he did his fellowship at Maimonides in maternal fetal medicine. placenta accreta spectrum, same topic, and continued efforts to reduce maternal morbidity. Basically the same. He's saying like this: if you know somebody who has placenta accreta, they need a team. Now, historically, in the past, when a woman went in for cesarean, nobody knew anything. An obstetrician would open a woman who was bleeding, get her baby out, and then see what kind of disaster he was dealing with in a hemorrhaging patient. A hemorrhaging patient with a closed cervix, she has to have her uterus emptied. So in the old days, the old timers, they would suspect it must be an accreta or an abruption, which is a premature separation of the placenta. And they would open it up and deal with the disaster. And the truth of the matter is, in the ways that they dealt with it, they dealt with it very well. Those are the days when I was a resident, and I have to say, we do it differently now, but the wisdom that the old timers had and the methods that they had to deal with this, thankfully, women were saved. And that was amazing. We use different techniques now. For example, in the old days, we would call in a GYN oncology surgeon in a hemorrhaging patient, and he would go in and ligate the arteries that supply the uterus, and that would decrease the pulse pressure, meaning less blood going into the uterus, more capability of gaining control over the uterine bleeding. So that was the way it was commonly handled. Nowadays, we handle that type of bleeding by taking the patient to interventional radiology. You don't have to open up the patient. For a woman who delivered vaginally, who's having uncontrolled bleeding, we could put balloons in the uterus, which we didn't have before. We used to pack the uterus with lap pads and open them up and ligate their arteries. Nowadays, you could put a balloon in and you could ship them off to interventional radiology, where they'll catheterize the arteries and put pellets in, and they'll stop the bleeding that way. So there's all kinds of new techniques now. So in the old days, the old timers had their way of handling it. And nowadays, with all these type of hemorrhage, placenta previa, placenta accreta, we would call in the GYN oncologist, because those are the GYN doctors. They do the big surgeries and they know how to handle big problems. And so his point was that we're OBGYNs, generalists, or high-risk OBs, and we're calling in an oncologist to come and actually perform the actual surgery, but we still need to get data from all of that and make it meaningful. So he's putting together, it's called complex obstetrical program, where he's trying to integrate all of this and come up with better surgeries with better teams. And he's working together with Dr. Shoshana Haberman, who's a genius at Maimonides, coming up with all these algorithms and publishing tons of papers. And I wish him the best of luck. He also loves to pull baby B out by its feet. I gave him once, I had a patient with twins and we had to pull baby B out, and I'm not about to give that away, but I did give it away to him one time, and the baby was born just fine. Okay, next. Dr. Sarah Carlini, the director of perinatal psychiatry department, Maimonides Health. Now Maimonides has a perinatal depression and anxiety, focusing on screening, diagnosis, and management. She gave a lot of stuff which we kind of already know. There are a lot of what they call validated screening tools. The validated screening tools are questionnaires to try to screen women for depression, anxiety, every other kind of illness in that category. We're used to that. She pointed out there's not enough screening being done. It's very prevalent. Yes, it is very, very, very prevalent. And what do you offer for someone who screens positive and they go for an evaluation and they get a formal diagnosis? So she's talking about psychotherapy and Zoloft, good old Zoloft. I would like to talk about lifestyle medicine, not about psychotherapy and Zoloft, because we know that ultra-processed food is associated with mood disorder. That has been proven beyond a shadow of a doubt. And so here is where it's missing. And I plan on emailing Dr. Carlini, would she like to collaborate with me on lifestyle interventions for women. There was not enough. Well, really, there was not, the word microbiome was not even used once the entire day. And the role of lifestyle, really percentage-wise, in terms of the whole conference, was small. So this woman in particular, I would really like to open a dialogue with her. But regardless of that, Zoloft is a pretty decent drug, and women do find benefit from it, so I prescribe it, and a lot of people prescribe it. And a lot of people who are not doctors, apparently, or nurse practitioners, or PAs, or midwives, a lot of lay people are prescribing it. I have to be quite frank with you that I had a patient who I thought was a candidate for Zoloft, and I sent her to a psychiatrist because I was a little concerned about some of the things that she was saying. I thought it was maybe a little more complicated, and that I needed to pull in a psychiatrist rather than just prescribe Zoloft for her, because some of her ideation or her thought processes I thought were like a little concerning, or let's say very concerning. But she never went to the psychiatrist, and she came back to me and she said, just give me the prescription for the Zoloft. There's a lady in the community who's going to tell me how to use it. And I'm like, what? What are you talking about? The lady in the community says she knows how to do it. She knows how to titrate it up. And I don't have to spend $1,000 to go to see a psychiatrist. I said, I'm sorry, I can't really do that. I really need to get you in to a proper program. If you want to do that, go to your medical doctor and he'll give you a prescription for Zoloft, and then you could take it to this lady. But I wasn't prepared to do that, not for this patient. That's what's going on in our community. Now, the last speaker was Dr. Kathleen Morell. She is also at Maimonides. She's the Associate Chair of Education, Residency Program Director, Director of Family Planning Division in the Department of OBGYN at Maimonides. What does she head up? She heads up a clinic called EPAC. EPAC means Early Pregnancy Assessment Center. There are a lot of women who have early pregnancy issues. Excuse me, I've been talking for over an hour. They have bleeding, they have pain, they may be undecided about whether or not they could keep the pregnancy. That could be a personal decision, or they might have a serious medical illness and pregnancy is dangerous at that particular time. And that can also apply to the Shomer Shabbos or Sabbath observing community. There have been instances, very rare, very uncommon. I know a couple of cases, less than 5 I would say, but there have been times when termination was approved rabbinically, and I'm not talking about rabbis who are not, God forbid, that they're fringe element rabbis, but let's say on the more modern end. I'm talking about Haredi rabbis who authorize termination due to highly, highly unusual circumstances. So a lot of these women wind up in EPAC. They have pain, they have bleeding, they don't know how far along they are, they don't know what they're doing. They try to get an appointment with their doctor, they cannot get an appointment. They might have an ectopic pregnancy. They might have what we call pregnancy of unknown location, meaning they've been bleeding and staining, and their beta HCG, which is the pregnancy hormone number, is less than 2,000, which is what we call the discrimination zone, where we could start to see a sac in the uterus. They need to be followed to make sure they don't have an ectopic. So the EPAC really handles this. And they handle it really, really well. Their hours have expanded. The other thing that they do, and I've referred plenty of patients there, is they take care of miscarriages. They can give pills for miscarriages, or they could do office procedures for miscarriages, and women don't have to wait. I do not have the capacity to do that in my office at the present time, and even in my old office, I would only do the really early ones. They are able to do more advanced gestational ages. They also do them in the hospital under general anesthesia when appropriate, and unfortunately, there are women who lose pregnancies in what we call the mid-trimesters, the 4th, 5th month, and they take care of those as well. And I work very closely with them. I have had certain feedback from certain people in the community that prefer to use Manhattan services for this, but I will frankly say that having an open communication back and forth with EPAC is extremely, extremely valuable. I find that a lot of these Manhattan mumchas, as we say, they will take care of the patient and send them back to you, and you really have no idea what was done. You don't have the operative report. You don't know about blood loss. You don't know if there were complications. There's no phone call. There's no communication, and they just come right back on your doorstep, and you're left in the dark. And then if there are problems, there's no one to talk to. So I really enjoy working with EPAC, and I would recommend that women take advantage of it. It's a very helpful service in the community. And that was the end of our beautiful symposium today. Dr. McCullough got up and thanked everyone, and we hope to have this annually, and the Department of Health does support it because we are a regional perinatal center, and we are a center of excellence for neonatal care, especially our neonatal ICU. I'm going to conclude by telling you about a patient that I took care of this past week, not from our community, from another community, but she came to Maimonides. She was a patient of a doctor in our department. It was a young woman, African American, has a family history of high blood pressure, and she herself was found to have high blood pressure, chronic, what we call chronic hypertension. She was put on a drug called Procardia to lower her blood pressure. She actually got admitted around 29 weeks. She missed her glucose challenge. She had trouble getting into the system and making her appointment. So we don't know anything about her diabetic situation, but she was not obese. She was normal weight, and she had high blood pressure. So she was sent home on Procardia. About 4 days later, she came back to labor and delivery, and she was bleeding. And she was bleeding a lot, and she was bleeding heavily. And the bleeding was also watery, so we suspected that she might have ruptured her membranes. She was only 30 weeks pregnant, 30 weeks and 0 days. We put her on the fetal monitor. There was fetal tachycardia. The baby's heart rate was in the 160s, 170s. And she was showing these little blippy things, what we call uterine irritability, not real contractions. A normal contraction pattern is a contraction and a rest, contraction and rest. She was just showing these little blips, which means the uterus was being irritated, and likely it was being irritated by blood. So we suspected that she was having a placental abruption. That means that the placenta is separating off the wall of the uterus, and there's bleeding behind the placenta. And this is a life-threatening condition, not only for the baby, but for the mother also, because if left unchecked and the mother keeps bleeding, eventually she's going to use up all her clotting factors. And when she uses up all her clotting factors, she's going to stop making clots, but she's going to keep bleeding because she has this abruption going on. And then this was a cause of maternal death in the past. Thankfully, we understand this illness much better, and so the treatment for placental abruption is empty the uterus. If the patient is close to delivering, if they're in labor and they come in with an abruption, often you can get away with it. But this woman was 30 weeks pregnant with her first baby, and the cervix was closed, and she was bleeding, and there were fetal heart rate abnormalities, and everybody said this is a textbook case of an abruption. And we knew we had to get her into the operating room. Now, you do that as fast as you can, because it's a race against time. She's using up her clotting factors, and she, at a certain point, can become unstable. So in order to get this patient into the OR safely, you have to draw labs and see what's doing, because she could already be having a disorder of coagulation. And if her platelet count, which is the little platelets, these little, there's no nucleus in them, but they're little cells kind of that are responsible for making blood clots. So we rush to see what the platelet count is, because if the platelet count is normal, then we can go ahead and give an epidural. So I was busy running around trying to get the CBC, which has the platelet count in it, and also to see how anemic she was. You're not allowed to scratch your forehead when you're doing a video on YouTube. I learned this already, but you know what? We're only human. So I myself took responsibility. I brought her CBC up, and it turned out it was clotted. It didn't work. We had to go down and get another CBC. We were wasting valuable time. They also had a hard time getting an IV in her because she had tattoos all over her arms. So whatever. And see, this is how things tend to drag on, and you know you're really racing against time. So I ran the second CBC up there. Her platelet count was normal, and we were very happy. We did not want to put her to sleep because she had eaten only an hour before, and that's dangerous. So she was able to get her epidural. When we opened the uterus, there was a skin and bones baby, really, really skinny baby, 2 pounds, 6 ounces, and this much clots. And I don't even know how much placenta was still attached to her uterus. And these things, they are what we say in Hebrew, it's a pachad, it's a frightening thing, because without the availability of modern obstetrics, this woman would have died. The baby would have died and she would have died. They would have both died. That's plain and simple truth. And when they used to say in the old days she died in childbirth, this is exactly what they're talking about. This is a woman who would have died. Thankfully, her life was saved, and she remained stable throughout, and she did really well. Her vital signs remained stable, and the blood loss, besides all those clots that were in there, was very under control. The baby was born Apgar, low Apgar. The 1 minute Apgar was low, but the 5 and 10 minute Apgars were good. That means the baby was under stress, but picked up right away with the proper resuscitation. And as I mentioned before, the baby was wrapped up in the aluminum foil warmer and was doing really well. They didn't even have to whisk off the baby to the ICU, this tiny pitsy baby. They were able to bring the baby over for the mother to see and then go to the ICU. So OBGYN is a really amazing specialty. It's very intense and it's intensive. It's intense and it's intensive. We have to really respect it. And we have to prevent cesarean sections. And the way to prevent cesarean sections is to be healthy and give over your healthy habits over to your children, because there is such a thing as epigenetics. Epigenetics means we have our genetic tendencies, but through our lifestyle we can turn on and off genes. So if we have a tendency to have, let's say, diabetes or high blood pressure, we can overcome that by lifestyle, and we can turn off those genes. And if we have average genes, and we engage in unhealthy lifestyle, we can alter those genes and we can have unhealthy outcomes. And these things can be transmitted to the next generation. So at this point in my career, I'm trying to focus much more on encouraging our community to pursue healthy lifestyles. And I'm not going to stop doing that. We have a butcher on every block in Borough Park, and we have a dreadful, dreadful lack of the proper fruits, vegetables, whole grains, beans, nuts, and seeds. So please take it to heart, and I hope to bring more of this type of content to you. I'm not going to say like and subscribe because it's irrelevant to me, but if you could just pass this around. Thank you very much.